Hello viewers, welcome to another exciting edition of our conversational podcast on IVF related matters. My name is Esther David. I'm an IVF administrator here at DIF Medical Center, Abuja. Our last edition was quite informative and expository. We got to know all about IVF treatment, the processes involved, the difference between in vitro and in vivo fertilization, and a whole lot more. As a matter of fact, I would encourage you to get the first edition and take a listen. Today, we're going to delve deeper into the process of IVF treatment. And taking us through this session again is our father, our mentor, and a boss in the field of assisted reproductive technology. He is none other than Dr. John O. Idahosa, Chief Consultant, Obstetrician and Gynecologist, Chief Medical Director, DIF Medical Center, Abuja. Sir, we are so honored to have you again on this program. And we feel very, very privileged to have you again.
Thank you.
Okay, sir. So the process of IVF, like we all know, is in stages. We have the stage of registering the couple, putting them through the preliminary stage, and then having their results revealed by the reproductive physician. And we start off with the treatment. The treatment has the preliminary stage as well, the preparatory stage, and then to the point of OCR. So I would like to know today, if you could give us an overview of what OCR is all about, the process involved, and then are the aftermaths of OCR?
Thank you, viewers, for listening. The OCRO is abbreviation for oocyte retrieval. OC stands for oocyte, the arrow stands for retrieval. Another layman's way of referring to it is egg collection.
Okay.
The moderator has said that the IVF is in stages. Actually, it's in 6 stages. And the OCRO is the 3rd stage, where the woman is prepared for egg retrieval or oocyte retrieval after the ovaries have been stimulated over a 14 days period. When the woman menstruates on the 2nd day of her cycle, the process of stimulating the ovaries commences. We use medications referred to as gonadotrophins, and then we monitor the patient's response by the use of ultrasound scan and hormonal assays. She will be scanned on the 6th day to determine whether the oocytes are responding to stimulation. On the 8th day of a cycle, another scan will be done to determine if the response is appropriate. On the 10th day of cycle, another scan will be done to determine whether the response is progressive. On the 12th day, another scan is done to determine whether the oocytes are ready for the trigger dose or for the introduction of what we call the human chorionic gonadotrophin, which brings about the final maturation of the eggs in preparation for oocyte retrieval on day 14 of cycle. Now, preparing a woman for oocyte retrieval entails a recognition that she's going to be doing this procedure in a very sterile environment called the oocyte retrieval theater.
Okay.
The oocyte retrieval process is done under anesthesia to mitigate pain.
Okay.
So preparations is designed to make sure she is safe during the retrieval process so that she does not suffer from any anesthetic accident. So she's prepared as though she's going to go through full surgery.
Okay.
Even if we're not going to, even if we're not cutting her, we're using needles through just one needle or two pricks through the vagina. But as long as she's going to be put to sleep, we got to prepare her to make sure she recovers well from anesthesia.
Okay.
And so the anesthetic preparation entails telling her not to eat for about 6 hours prior to surgery, prior to procedure, because she's under general anesthesia. And the reason we're saying you should not eat, it's because we don't want you to vomit recently ingested food and then you inhale it. And that will cause aspiration pneumonitis, which can lead to death. So we also would take your blood samples to make sure that your blood level is good for general anesthesia. Okay. We make sure your kidneys will respond appropriately. Okay. We'll do your liver function test to be sure the liver will cooperate with us. And listen to your chest again and be sure that the chest will perform well. Okay. Then we'll take your pulse rate, your blood pressure, and all those vital signs that we need to just check to make sure she's safe during anesthesia. So you see, it's all about anesthetic preparation. Okay. Now, before she leaves home, we encourage her, because we're preparing her for OCR, we encourage her to douche her vagina with salt and warm water, so she cleans up herself very well. Okay. We encourage her to take a bath very well with a non-scented soap. Okay. She's also advised not to put on perfume. She's not supposed to use deodorants. Okay. And as part of the preparation, she has to make a hairdo that will allow the anesthetic unit to manipulate her neck. So the idea of doing a hairdo that you will now pack it towards the back, no, we won't allow it. Okay. Because in the event that we need to do something more urgently, that hair will be scattered. Then the nails, most women would have fixed some maybe acrylic nails. We will expect her to remove one. If there is a nail that is painted, we need to scrape out one so that we can put our vital signs monitors, and they need to pick it well. And those paints can prevent us from getting proper recording in our electronic monitors. Okay. Part of preparation will entail that she should not use lipstick. Okay. Because we need to use the lips to monitor her response, or her response to anesthesia. Also, we want to be sure she's not pale, which the lipstick can hide. So you see that it's a full body preparation for the procedure. Now, when she's ready, about 15 minutes to the time of OCR, because the OCR is done, the eggs are collected anytime from 36 hours after the triggered dose of injection has been given on the 12th day. Okay. We tried not to miss this 36 hours because thereafter anything can happen to those oocytes. They can rupture by themselves inside the body. So about 15 minutes to the 36th hour, she's taken into the theater, and then those preparations, the anesthetic preparations will commence. The team that is to do the egg collection will already be inside the theater. She's likely, before she enters, she's changed into an operating gown as though she's going for an operation. Okay. If the spouse wants to be there at the egg collection, the spouse is also supposed to have his bath properly, and he's not supposed to use deodorants, no perfumes. And then the next thing will be, we also give him a gown to wear, we give him a face mask, and we give him a headgear. So while already inside theater in a very sterile environment, then the process is done, and the scan machine is ready, and then we repeat that scan we did on day 12. Another scan is done again. At this scan section, we will assess both ovaries while she's already under anesthesia. We'll determine the number of follicles, their sizes, we record them, and then we press the button within the ultrasound scan machine that will give us what we call a biopsy line. It's like a pilot being told from beginning, hey, this is your path from Abuja to Lagos. Stick to that path. So that's what the scan machine does also. It gives us the path to follow. And then once we're there, the process begins. The probe is put into the vagina. We're still describing the OCRO.
Yes.
Okay, so the probe is put in the vagina. But this time, the probe is attached to what we call a biopsy needle.
Okay.
It is through the biopsy needle we pass the needle. And the scan recognizes the presence of the biopsy needle. And so once we press the button, we're not puncturing anyhow. It's a line that we're supposed to follow, and our job is just to follow it. And then OCRO will puncture the follicles. As the follicles are punctured using the aspiration needle,
Okay.
the ultrasound scan is showing the needle.
Okay.
The ultrasound scan is also showing that the follicles are emptying. It's emptying into a tube.
Okay.
This tube is in a warmer.
Okay.
So each follicle is emptied into maybe separate tubes. The tubes can take 10 ml of fluid. So what we are puncturing is the follicle that contains fluid and expected to contain an egg.
Okay.
But it does not necessarily mean that if I puncture 10 follicles, I get 10 eggs. No.
Okay.
If I puncture 10 follicles, I may get 6 eggs. The older the woman, then the less the eggs you will find per follicle, per puncture.
Okay.
Each follicle should contain 1 egg. But sometimes the follicle is empty. And if you're not lucky, all the follicles can be empty, which we call the empty follicle syndrome, common in conditions like the polycystic ovarian disease. So the eggs are inside the fluid. It's inside the warmer in a test tube that can carry 10 ml of fluid, and then intermittently this is transferred using a warmer to the embryology unit, and the embryologists now pour the fluid into a dish, and from that dish they are looking for eggs, and then they determine whether those eggs are mature. They grade those eggs, and that continues. So do the left or right, finish those follicles, and then we use the ultrasound scan to do a general examination, evaluation of the pelvis of the woman. Now that she's under anesthesia, we look at the uterus again, look at the endometrial lining, look at the patch of Douglas, which is the back of the womb, to be sure there is no fluid at the patch of Douglas, because if there's fluid there, then it means that's blood. We drain it, we empty the bladder to be sure that we did not puncture the bladder, but even if we did, it will heal. It's just 1 or 2 punctures that went through it. And that is done, OCRO completed, the anesthetics reverses the patient goes back to the room. This whole process will last 15 to a maximum of 30 minutes, depending on the number of follicles the patient has.
Thank you so much, sir, for that detailed explanation and description of the process of egg collection. Sir, you did mention while you were talking that the couple, the woman and the husband, if he intends to watch the process, are not allowed to use scented soap or perfumes or deodorant. Could there be a reason for that, sir?
The reason is because virtually all perfumes contain volatile organic compounds, VOC, because perfumes are made from crude oil and they're processed. Volatile organic compounds do serious harm both to eggs, sperms, and embryos. So before we do egg collection each day, we use our VOC meters to record, to take measurements. That's why we have 2 theaters. If one theater has been mistakenly contaminated, we use another theater.
Okay.
to make sure the VOCs are reduced. And to make sure the VOC is minimal, we have air filters designed to remove VOCs and remove some viral particles from the air, make sure we have a clean air.
Wow.
Because it's good, we all know that the air quality in the IVF theater is the first determinant as to how the eggs and the sperms are going to grow and develop.
Thank you very much, sir. Out of curiosity, I would like to ask, sir, are there adverse effects to oocyte retrieval? Is there an aftermath of the procedure? Do women react sometime? Because we know that, yes, the ovary has been stimulated, instruments have been taken there and all of that. Is there an aftermath, sir?
Well, the aftermath of OCRO is like asking me, are there possible complications?
Yes,
That's
sir.
the question.
Yes, sir. That's the question.
Now, it's good you know, because if you know something, then you prepare for it. One possible complication is a complication of anesthesia. Oh, the woman was injured, the lips injured, the tongue injured, the throat bruised while trying to put her to sleep. But these are minimal things, minimal complications. Then she reacts to an anesthetic agent. But in a place, in a facility like this, where before we put you to sleep, we would have connected you to a lot of electronic monitors, those complications are minimal. We've not seen any in this hospital. We are 21 years in practice. So it means that it's something that can be mitigated. Then comes where we are doing the procedure. We're going to pass a catheter into the bladder. So to pass the catheter, we go to the urethra. So for some women, that may be the first time a plastic is passed into the urethra. So when she wakes up, she wants to go and urinate, she may find a burning sensation. Now, in order to further clean the vagina, we're going to pass a speculum into the vagina. Now she's asleep, so she's not likely going to complain that there is pain or something. So again, a little bruise, and so she feels some soreness in the vagina. The other thing is we're puncturing the upper part of the vagina with a needle.
Okay.
Now, I don't know, these needles are quite expensive, but do you want me to open it, or you want to give me one? I can't.
You can't open it.
I can't open it,
but
this is how it comes. Comes sterile. It comes very long.
Yes, sir.
The needle is as long from here to here, and somebody will just be wondering, "Hey, are you going to put all these into my body system?" The answer is no. We're going to just put the tip. The vagina is 10 centimeters long, so it's this part will be inside the needle guide. Immediately the needle guide touches the upper part of the vagina, we will sit on scan. We advance a little bit and use just the tip. So which part of the body, which part of this long tube now we enter? Maybe just 1 centimeter of this will enter into our body. Now we are using this to puncture the vagina. And then we're puncturing the ovary. That puncture site may bleed. So she may now notice that after egg collection, she is having some minimal bleeding. It's supposed to be minimal.
Okay.
If it is too much, we'll stop it. It can never be a problem because it's a vaginal puncture. Now we're also puncturing the ovary. So when you puncture the ovary, you can also bleed. The woman can bleed because you're passing through vessels. Again, that we will see. If the woman is not well prepared, the vagina not well cleaned, then you have passed bacteria from the vagina into her peritoneal cavity, into her body system. We can also notice that, and then she will have post-collection pelvic infection.
Okay.
Minimal. In a place like the DIF Medical Center, we mitigate that by preparing her preoperatively. So before she even does egg collection, when it is 5 days to egg collection, she starts what we call a preventive antibiotic care that will take care of the common microorganisms you can easily find within the vagina. So that mitigates the complication of infection. All right, then comes the last of the complications, which most gynecologists and reproductive physicians are scared of, is called the ovarian hyperstimulation syndrome. In this ovarian hyperstimulation syndrome, we may have emptied the eggs, but the last injection we gave, called the HCG, which is the trigger dose, she may have an exaggerated response to that medication. So in spite of the fact that we empty the eggs, you go back there in 6 hours, you see as if all the follicles are back there. The ovary becomes enlarged.
Okay.
Because the ovary is enlarged and enlarged, post OCR, she can have pelvic pain.
Okay.
She will have heaviness of the lower abdomen. Okay. When she goes to pass urine, she feels pain. Okay. She's just feeling a little bit bloated, heavy. She may even pass a little blood vaginally. She can pass it from the urine. And she's a little bit drowsy. She's feeling weak, all because of the effects of drugs and the procedure. But also, we anticipate OHSS, okay, and we mitigate, we handle it.
Okay, thank you so much for the time, sir. Okay, we know that once the oocytes are retrieved, the sperm is gotten to inseminate, and embryos are generated. We'd like to ask, sir, what is an embryo transfer?
Okay, thank you. Once the eggs are retrieved, they are coming out of a battle zone.
Okay.
They've been in a state of rest. So first thing first, you allow them to relax. So wait for the eggs to relax.
Okay.
So that will take about 4 hours. Thereafter, we will then inseminate it. I'm sure the embryologists will come and tell us how they do the insemination, whether it's going to be basic in vitro fertilization or intracytoplasmic sperm injection. Embryos are generated. Now, by the second day, we'll start looking at the developments. In the DIF Medical Center, we wait until the 5th day.
Okay.
The day of egg collection is called day 0. So it's the next day that is day 1. By the time with the embryos at day 5, it's actually 6 days post-OCR. Okay. At that time, the embryos have reached what we call the blastocyst stage. They've been given the opportunity to give a full expression to their God-given potentials. And then we're ready for transfer. So, you want me to describe embryo transfer procedure?
Yes, sir.
Oh, when it is now time for embryo transfer,
yes, sir,
we'll again prepare the woman.
Okay.
What do? The same precaution she took of making sure she doesn't bring in volatile organic compounds into the theater will be, those principles and practice will be upheld. But now we're doing the embryo transfer without anesthesia, so she can eat. The only thing she will now notice is that we're asking her to come with a full bladder. So 2 hours prior to embryo transfer, we expect her to come to the room, relax, and just begin to take some little water. We do not want the bladder over distended. We just want a full bladder. Egg collection is done with an empty bladder. Embryo transfer is done with a full bladder. Now, again, she gets into the theater, changes into the gown, the cap, the face mask, no makeup, no perfumes. She would have also doused the vagina. We get there again. We clean the vagina very well again. And then she's positioned with her legs put in what we call the latotomy position, and then expose the cervix. Once we identify the cervix, we take a swab stick, clean up the cervical mucus from the cervical canal.
Okay.
So we put a speculum into the vagina. The aim of putting the speculum is to expose the cervix. Okay. So with the cervix already exposed, we will see the opening of the cervix, which is called the cervical external os. Then this is the canal. This is the internal os. So once the external os, once we see the external os, we'll pass in a swab stick to clean up this cervical canal. We may be here for 10 minutes. Whatever we don't clean here will become an albatross. Because if you do not empty the canal of its plug of mucus, then it has the capacity to trap embryos. If we use a swab stick for long and we notice that the canal is still not cleaning up, we will use what we call as a cervical mucus plug extractor to just pull it out. The idea is to make sure the canal is free. All right, and then prior to this period, we would have done what we call a mock embryo transfer. The embryos are going to be dropped 1.5 centimeter to the uterine fundus. If you drop it on the fundus, pregnancy may not take place. Even if it takes place, you're going to end up maybe with ectopic pregnancy. Okay. So if you drop it too low, it will fall out because it's too close to the internal os. So we drop the embryos 1.5 centimeter here. We already know that. But on that same day, the embryo transfer is done under ultrasound sky guidance. Once we drop it, we know it's there. Yeah. And then we scan after the transfer to be sure it's there. Of course, before we do the embryo transfer, the woman is taken to the embryology laboratory to see the embryos herself and know that this is what we're going to be doing. Naturally, in case for those of you watching on the screen, you will hear the embryologist coming to confirm your name. Oh, are you Mrs. ABC? They want to be sure you are the one so that we do not mix another person's embryo. Though we know this, yes, but as a final witness, yes, we will ask for your name. So don't get agitated. How come they didn't know I'm the one? We know you are the one. Yes. We just want to make assurance, triple sure. Once we do the embryo transfer, drop the embryos, we wheel you back straight into the room. 15 minutes later, we ask you to go home. Wow. People have wondered, won't the embryo just drop since you're asking me to go after 15 minutes? No. Embryos don't drop under gravity. The embryos that are going to stay, immediately you drop them, the process of implantation has started. Now, this is the embryo transfer catheter that is used. This catheter has this outer sheet, which is sturdy. Then it has the inner sheet, which is flexible. So we use this sturdy one to go through the cervical canal, and we position here. The embryologist uses this part of it to pick the embryos. So when they load it, the embryologists are very good in loading this thing. They easily just see this thing. They see it. How they manage to see it, we don't know, because sometimes you would think their hands will be shaking. It doesn't just shake. They just load it. And once they get midway, they leave it to the person doing the embryo transfer. Then you use your best hand to do the monitoring. For those of you watching on screen, peradventure, there's going to be an embryo transfer in which I'm involved. My own role during the embryo transfer is the ultrasound scan, because you use the best person to do the ultrasound scan while others will do the procedure.
Okay, thank you so much, sir. So, sir, how long does a woman need to wait after an embryo transfer to do a pregnancy test to know if she's positive or it's a negative outcome?
14 days. 14 days you do a urinary pregnancy test. But actually by the 12th day, if you do a blood pregnancy test, you'll get it.
Wow.
You start knowing that this pregnancy is likely going to be, this procedure is likely going to be positive.
Okay, sir. Good. And then what should the woman do after a positive outcome?
Oh, well, people even wonder, what do they do after embryo transfer? Should they go to work? Should they even just lie down on the bed? Should they greet people at home? There's nothing we don't hear.
Yes.
I want you all to understand that embryos don't drop under gravity. But you can also do an embryo transfer and go and run a 100 meters dash. So it's a mixture of using some common sense. Reduce physical activities.
Okay.
Avoid sexual relationship. Okay. Not because the sperm will go and damage the embryos. No. It's because the semen contains a chemical called prostaglandin that has the capacity to cause this uterus to contract and expel. That's why we say avoid sexual relationship. Avoid taking alcohol or caffeine, because it can, by the way alcohol and caffeine works, they might make you produce the hormone called oxytocin, which has the capacity to also make the uterus to contract. We encourage spouses to avoid fiddling with the nipple of their spouse after an embryo transfer, because the process of fiddling with a woman's nipple has the capacity to make her brain, the pituitary gland, to produce oxytocin and prolactin, which can make the uterus to contract. Now, can she go to work? The answer is yes. Can she go and cook? The answer is yes. Can she drink cold water? The answer is yes. Warm water? Yes. So what should she avoid? Just avoid those things I've said, and avoid any food in our place, any food that contains potash, because potash has the capacity of causing some uterine contraction. Now, depending on where you come from, you know what contains potash. For the Hausa woman, it may be kunu.
Yes.
For the Igbo woman, it may be Isiewu. For the Edo woman, it may be owosu. You know, for the I don't think Benue people have anything that contains potash. So let's not go there. Maybe they don't have potassium where they are, but that's just by the sideline. Now, your real question is what to expect after a positive pregnancy turnout. Well, once the pregnancy test is positive, we'll wait for 2 weeks to do an ultrasound scan. The purpose of that ultrasound scan is to determine whether there is a gestational sac, the number of the gestational sac, the shape of the sac. Okay? Yes. So, the mere fact that your pregnancy test is positive does not mean we're going to find a sac. So, if pregnancy test is positive, we're not seeing a sac, 2 possibilities. It means you have a chemical pregnancy, or you have an ectopic pregnancy. So, we'll find out which one. Okay. Now, if we see a sac, we'll look at how is this shape. If it's regular, we want to determine, does this sac contain a fetal echo? Is there a baby inside the sac? Because you can also have a sac that does not have a fetal pole inside. Now, if a fetal pole is inside, the baby is inside, is there a heartbeat? Because you can see a heartbeat from 5 weeks, 5 days. Okay. And then you now decide the number. Oh, she has 3 gestational sacs. She's 54 years. Of course, you want to prepare to reduce it to what is manageable.
Okay. Thank you so much, sir. Sometimes we know that it turns out negative as well.
Yes.
And then at those moments, it could be really devastating.
Correct.
And emotionally demanding for the woman. So what should the woman do or know after a negative outcome? Is that the end of life for her? What should she know and do?
She should know before she even starts the journey. That's a long journey. So when you want to prepare for a 100 meters dash, the way you prepare is different from when you prepare for a marathon. So when you're preparing for a marathon, you develop your stamina. When you are preparing for a 100 meters dash, you prepare your speed. So IVF is a marathon. Now, the idea is this. When you prepare for a marathon and you run 100 meters and it's finished, oh, you have a lot of energy left. But if you prepare for 100 meters only to discover that this is a 5-kilometer journey, then you are discouraged. So all women are supposed to know that no woman is considered to have failed in the field of assisted conception until the 13th consecutive attempt. And each attempt prepares you for success. Wow. And the time between one embryo transfer and another one should also not be more than 13 weeks. Okay. So that you can maximize the advantage that a previous embryo transfer has conferred on you. So prepare to run 13 consecutive attempts. But if you run one, fantastic. At the DIF Medical Center, our lowest success rate is 63.7%. In other words, if I take 10 women through an IVF program, 6.3 will get pregnant at their first attempt. The remaining 3 or 4 may have to do it several times, 2, 4, 8, 10. Invariably, everybody gets pregnant in this process. If you have the inner will and courage to run 13 consecutive attempts. So, if the pregnancy test is negative, what you need to do is relax your mind and tell yourself this is not the end of the world. I've been told from beginning there's a 13 consecutive attempt. Get ready to run on that one immediately. But the problem we have amongst our people is that when there's a negative pregnancy test, they spend the first 1 month lamenting. It's just all about lamentation. The second month is they begin to ask the question, why me? They use the third month to blame everybody, the sister, their father, their mother-in-law. That's 3 months have gone. Yes, they spent the 4th month going from one prayer and fasting or the other.
Yes, sir.
They spent the 5th month taking counsels from anybody. And then they start drinking purple leaf. And then by the time they come to terms with this, saying that, oh, this is a negative pregnancy test, 7 months have passed. When they come back, they return back to square zero. The body begins to treat them as if they never did IVF before.
Yes.
So, distinguished audience and listeners, please, I urge you, why will make, and it's always our joy, it's our pride that a woman did an IVF program and at the first attempt, she got pregnant. That's our joy.
Yes.
That's our pride. That will make us stick. So that each time a woman has a negative pregnancy test, we feel the pain, the tears, the shame, the despair she's going through. We don't like it.
Yes, sir.
We don't, it's not the fact that you're coming to pay a second cycle does not mean anything to us. At least not at the DIF Medical Center. It doesn't mean anything to us. It is that you got pregnant the first attempt, that's our joy. So we put all our lives into it. That's why once it's negative, the entire team must appraise why did this woman's pregnancy test come out negative. Because we take it seriously. I know what it means to be in the waiting room. I was there for 9 years. And so whatever we can do to mitigate the pain, the tears, the shame, the despair, the inconvenience that follows assisted conception or infertility, we put our life into it, knowing that our value and purpose in life is measured by how many of these women, how many of these couples we've been able to create tunnels of hope.
Thank you so much, sir, for this time. Thank you for always obliging us the privilege to any time we come calling. And we have heard it all, audience. Remember, he said, no woman has failed in the field of assisted reproductive technology until the 13th consecutive attempt. You don't have to get to the 13th attempt, but we encourage you to gather momentum and face it again if the results are negative. Until we come your way again, stay focused, stay glued, and know that IVF is a way out. Thank you very much.
Thank you.